and another more monotonous appearing proliferation. If the differential diagnosis here is low-grade DCIS versus hyperplasia without atypia, you can use the immunohistochemistry. But in my opinion, the final diagnosis is going to be based on H&E. Here, even though the cells are spindle and more atypical, more hyperchromatic looking, the monotony of this lesion makes the diagnosis of low-grade DCIS as opposed to hyperplasia without atypia. Another lesion involving areas of adenosis, these florid epithelial hyperplasia sometimes can be mixed as a UDH or as a DCIS, a little out of focus, but identification of these irregular spaces and presence of more than single type of cell is the diagnostic criterion for hyperplasia without atypia. So in DCIS lesions, the uniform expression of estrogen receptor is helpful as opposed to mosaic appearance of cytokeratin 5 in hyperplasias. And this is cytokeratin 5 expression in DCIS, where you can have the myoepithelial cell positivity around, but the proliferating cells are negative. Another case of epithelial proliferation involving sclerosing lesion, cells are spindle, and the mosaic pattern of cytokeratin expression and ER positive but not uniformly positive that are negative cells. So again, this was a hyperplasia without atypia. So identification of these patchy areas of lack of staining for cytokeratin is the hallmark for atypical hyperplasias. And again, in my opinion, 90% of the time, these areas is appreciable on H&E staining. So in general, ADH versus DCIS, immunohistochemistry has no role because these are psychologically identical cells. So in terms of low-grade lesions, is it an ADH or DCIS? Let me do the immunohistochemistry is a wrong approach. If the differential is hyperplasia without atypical versus DCIS, yes, you can use these markers. And it is very important to use what type of keratin that you are going to use. Some of the cytokeratins may contain cytokeratins other than cytokeratin 5 and 6, and depending on the antibody that you are using, you may get some non-specific staining. So in general, for the classification of intraductal lesions, distinction between hyperplasia without atypia and ADH is primarily based on morphology, but in isolated cases it can be used. Another application is, as I indicated before, classification of carcinoma. In that, I personally use Ekaterin staining most frequently than any other stains in breast pathology, especially when you have these intraductal carcinoma cells involving involular units. When there is a low-grade intraductal carcinoma, the distinction between DCIS versus LCIS, in my opinion, can be problematic on H&E. And the only distinguishing feature that I can reliably use is the presence of lumen formation. If I do not see any lumen formation in these areas, that is more problematic when the lesion involves in lobular units, then I perform immunohistochemistry for Epithelial. So that is probably the most common use of immunohistochemistry I do in my practice. A lot of the lesions can show mixed patterns, but when I see loss of epithelial positivity in a uniform epithelial proliferation with appropriate cytology, I would make the diagnosis of lobular lesion. Metastatic tumors to the breast is a very important area, and even though this is not a common lesion, we always have to remember it. Recently, we completed a review of our metastatic carcinomas in MD Anderson, and it is a lot more common than we originally thought. And just like all the other reports in the literature, malignant melanoma is the most common tumor that metastasizes the breast. And this metastatic tumor creates problems in two different scenarios. One is when you have a metastatic carcinoma somewhere in a solid organ, such as in liver or in lung or in axillary lymph nodes, on a patient who does not have an established carcinoma, and always the question comes up, is this a breast primary? And then the second is when you have a tumor in the breast and then you do not have any other primary tumor, and then the question is, could this be a metastatic carcinoma, especially on corneal biopsies? If the patient is a known primary, the most important step is definitely to review the previous slides. To me, I cannot really overemphasize the review of previous material. No matter what specific immunohistochemistry, how many markers that you are going to use, there are always variations, there are always different patterns. So I cannot overemphasize this review of the previous material when you are trying to make the diagnosis or exclude the diagnosis of metastatic carcinoma. IHC might be necessary only if the histology is equivocal. So if you have a patient with a known ovarian carcinoma and you look at the ovarian carcinoma as a high-grade papillary serous carcinoma and your breast looks very similar to it, identical, then you can make the diagnosis. But you can do immunohistochemistry to confirm it. So I would say IHC again should be done on selective cases. If you have a unknown primary, so the patient doesn't have a primary tumor and you have a now either a solid organ metastasis or this is a breast lesion and there is no inside the carcinoma, so you are questioning if this be a metastatic tumor, then we have to develop a working differential diagnosis. I would not say, what is your panel for an unknown primary? I don't have a panel. So I look at the histology, and based on the histology, I would develop a working differential diagnosis and utilize the markers based on that marker. In terms of separating tumors from lung primary to renal cell, pancreas, we start with the common markers. And in terms of being a specific breast markers, there isn't any single marker that is specific to breast epithelial. So the most commonly used markers are the gross cystic disease fluid protein 15, mammaglobin, and GATA3, and none of these markers are specific. And presence of GCDFP15 is fairly specific, but the sensitivity is can be quite low. And the positivity can be seen in salivary gland tumors, which is very important because we have seen metastatic salivary gland tumors in breast, and they are histologically mimic ductal carcinomas. Prostatic adenocarcinomas in males can be positive, and more importantly, the staining can be extremely focal, especially if you are dealing with needle biopsies. On the other hand, mammaglobin sensitivity reported to be around 50 to 80%, and endometrial and ovarian carcinomas can be positive. And we saw 2 melanomas, they were positive, which I really didn't know, but when I did an extensive literature search, actually mammaglobin could be positive in melanoma, so we have to be extremely careful on that. GATA3 at this point is the most commonly used marker. If your question is lung versus other solid tumor, and the presence of nuclear staining is very helpful. And this manuscript is really one of the most comprehensive review of GATA3 staining, showing the staining in ductal carcinomas and normal ducts and metastatic lobular carcinoma. And they really did a very thorough evaluation of different types of tumors. Commonly, in addition to the common tumors like urogenital carcinomas, endometrial adenocarcinoma, ovary, and many other types of tumors can be GATA3 positive. So any, and this is true for many other markers, any immunohistochemistry positivity should be evaluated in conjunction with histology features. One very important aspect of GATA3 is that it's a perfect marker for especially estrogen receptor positive tumors. But if you are dealing with triple negative carcinomas, either as a primary triple negative carcinomas or metastatic triple negative carcinomas, the positivity can be very focal. And even if you are going to accept any positive staining as positive, or more than 5% of the staining positive, which is a very arbitrary cutoff point, the sensitivity of the GATA3 is not that great for estrogen receptor negative tumors. And if you look at the GATA3 positivity versus other breast so-called specific markers, GATA3 staining tends to be more diffuse positive than especially mammaglobin, because sometimes you can have all of these scattered positive cells. So in general, GATA3 is a little more specific, but this panel of 3 markers is usually more commonly used and recommended. The sensitivity in the triple negative breast carcinoma is moderate, and especially if you are trying to exclude the breast as an origin in an unknown primary in a triple negative breast carcinoma, pretty much you can never exclude breast carcinoma. If you are dealing with microcapillary type breast carcinoma, I find EMA and that reverse polarity of staining of EMA is a very helpful marker, but again, I use it specifically for these microcapillary carcinomas. So the bottom line is selection of immunohistochemistry marker depends on morphology. TTF1 we extensively use to differentiate lung versus breast carcinoma, but you have to remember that some breast carcinomas can express TTF1 staining. This is an example from this manuscript where not only the invasive carcinomas but also the CIS can be TTF1 positive. I have seen 3 cases, but I have not done extensive TTF1 when the cases were clearly breast, so I don't know the actual extent of it, but it can happen, so you have to be careful about that. And similarly, some lung carcinomas, it's less than 5%, but when you are dealing with large number of cases, they can be gross cystic disease fluid protein positive, and they can be TTF1 negative. In our institution and many of the cases that we receive, the lung lesions, the biopsies tend to be a lot smaller than breast biopsies. So when you are dealing with small biopsies, be extremely careful. So the focal gross disease fluid protein positivity, don't jump into breast carcinoma diagnosis. The traditional teaching is that breast metastatic carcinomas, they are usually bilateral, multifocal. Ipsilateral lymph node involvement is not that common and lacks inside the carcinoma component. In our recent review, we actually disqualified almost all of these points. And when you do an extensive literature search, actually most breast metastases are unilateral lesions, and most breast metastases are unifocal. Yes, if you have a multifocal lesion, it raises your suspicion, but in general, most breast metastases are unifocal. And similarly, age is not a dependable marker, even though on average the age is lower in metastatic carcinomas than primary breast, but you cannot use this as a marker. Again, ipsilateral lymph node involvement could be seen in metastases. Again, it's not a final thing. Presence of clear-cut DCIS obviously is indication for primary breast carcinoma, but again, we have to be careful on that. So presence of well-circumscribed pushing borders is a favorite feature for metastases, but we can have breast primaries. So in summary, in breast pathology, diagnosis should be based primarily on H&E morphology. Use of IHC can be adjunct to diagnosis, and it can be used, but H&E diagnosis is the gold standard. Thank you very much for listening.
Thank you. Thank you very much, Aysegul, for a very wonderful and informative talk. And let's put the questions to the end of the last speaker, so we have time to discuss with them anything. And our last speaker, actually, she is well known to all of us. She's not the first time for her to come here, and I'm so lucky. I always introduce her. I don't know why. Maybe because I like her. She has been my friend since a long time. And she is Professor Ruba Ali. All of us know her. She is of a Syrian origin, actually. That's why her name. And she's the director of the UIL Pathology Session Recruitment Program and director of the Surgical Pathology Fellowship Program.